Good morning. Describe a critical time when nodal staging may be challenging but still has profound implications on a management for a patient with esophageal cancer.
Well, I think nodal staging is always important in clinical decision making, but it's not too challenging, for example, in T1 and more advanced stages of tumor. So I would think the most challenging one is a T2 NO clinical stage. So in those patients, the accuracy of clinical staging is maybe 50% at best, and that can have profound implications for the accuracy of your clinical decision making. So in my talk, I go through some of the relative accuracies for CT, PET, and EUS in the clinical staging of nodal disease, and then talk about some of the potential advantages of using more technology, more frequently use PET and EUS to improve the accuracy of staging, but also look at a variety of factors that can influence the accuracy of clinical staging. So I classify them as biological factors, technological factors, and systems factors. So when we look at biological factors that might help you decide how aggressive to be about clinical nodal staging, we look at T-status, location of tumor, the grade of the tumor, the histology of the tumor. And technical factors, we look at improving the accuracy of CT, accuracy of PET, new PET modalities and new camera technology. Look at the overall accuracy of EUS, the combination of those, the utility of EUS in CT and PET negative, node negative tumors, and then try to combine those into new algorithms for staging. And then in terms of the systems, looking at the current TNM, the potential advantages of the AJCC8 TNM system, looking at the possibility of getting rid of the N0 through N3 status, which is very difficult to determine clinically, and maybe creating new clinical staging, which would be N0, N few, N many, and use that for clinical decision making as opposed to prognosticating survival. And so there's some of the things that I do with my talk I think people might find of interest.